Thank you very much. I wish you all very good afternoon. I want to thank you, Professor Sadikot and Professor Sabu, and especially I want to thank to all of the students actually who are also catalyzing my coming actually here. That is almost 200 students who finished the Zagreb Diabetology School and has, I would say, very important places in Indian diabetology. So, out of the topics I suggested, that one was actually chosen by the organizer. Why are sulphonylurea drugs different from other hypoglycemic drugs? So, listening today about a lot of different compounds which are already waiting for pipeline, how deep we are actually moving to the cell, how many things are actually happening. It looks very small, it looks very old, but anyhow, I think it's worth to discuss that and to recognize some of the things what we just bought as an argument, but as a problem, never think about even more. So, conflict for interest for this presentation for the retired professor does not exist anymore. So, let's say a few words. Sulphonylurea definitely cheap. We know that it is really cheap. When we are looking to the evidence-based medicine, most of them are associated with a high risk of hypoglycemia, and new formulation should be used. That's very high on the evidence-based medicine. I want to say, and I will repeat it later on, we definitely have the clear proofs through evidence-based medicine for such a command. But the thing what we do not know is how the patient will react on that. So we will touch that point because a lot of data relating to this command still relates to the history when we do not know how the drugs were used, what is happening with blood glucose self-control. For some of the very old study even didn't have hemoglobin A1C for judging that. So is it really true or not? We will just try to think a little bit about. Regardless of treatment modality, intensive therapy for diabetes associated with increased risk of hypoglycemia, also very high in evidence-based medicine. Impaired awareness of hypoglycemia increases the risk of severe hypoglycemia too. But is hypoglycemia always the main problem? Did we ever think that during 24 hours we have actually the time period with hypoglycemia and in the same 24 hours the time period of hyperglycemia? Actually, both of them actually has a pathogenic effect. So we have to recognize that evidence-based data are not definitely appropriate to all diabetic patients, so we will just touch it in a few words. Only blood glucose self-control can give appropriate information about individual patient pharmacodynamics or sulphonylurea used, same with insulin or some other drugs which can be used in everyday treatment. So we will touch at this point because that is something which is still not deeply involved in our everyday work. I'm not talking about continuous blood glucose monitoring, which is much better than blood glucose monitoring per se. But anyhow, at least blood glucose monitoring has to be involved. So then very recent paper, do we have sulphonylurea overtreatment, especially in the old age? We will try to tackle that with a little problem. And is that critical problem really medical, or is that the profit problem? So let's go further. Effects of uncontrolled type 2 diabetes is problem of hyperglycemia and hypoglycemia. So even mild hypoglycemia can be very, very, very frightening for the patient, especially in the elder population, I agree. If we have good regulated glycemia in all the patients with sulphonylurea, even very light hypoglycemia can be very, very, very dangerous for the patient. But definitely, that is a problem much, much more of the parallel comorbidities of the patient than the complication itself. So, I think that that is no treating diabetes, hypertension, hyperlipidemia, joint disease or whatever without proper self-control, which includes the education, self-control, running some sort of drug between hyper and hypo to the life without complication. Doesn't matter. Do I have self-control once a day, 10 times a day, or once a week, or once a month? I have to be in contact actually with my glycemia, which during the day, showing what is happening during the day with my treatment. Where are my mistakes? Where are the problems of hypoglycemia? And does this drug really work 24 hours or is work only part of the time? We will see some examples of that. So that is this known place for how to perform hypoglycemia, something what we are putting everything in one day in intensive care unit and some sort of forming the glucose profile for some certain period of time, depending on the possibility to get strips, not get strips, or some other things. So this black slide actually shows that is driving a truck with the closed eyes. It looks completely stupid. But it is not, we do not manage that as stupid. Treating diabetes with closed eyes, meaning without blood glucose self-control. So I definitely think that these two things has to go together. So, looking to the list of medication, now we are coming closer to the problem of sulphonylurea. Actually, we can see, I try to put it in three parts. We have the insulin group, which has certain hemoglobin A1C decreased values, some pro and contra. So we have the sulphonylurea group. We see that it goes, let's say, to 3%, it goes to 2%. And then we have the whole bunch of the drugs now, previous and now, which hypoglycemic effect is definitely not so strong like sulphonylurea and insulin. So, and we understand that our controlling disease with insulin is different of controlling with the other group of medical drugs. But I want to point out and I just want to discuss with you, I think that even sulphonylurea, this group with a stronger hypoglycemic effect, has to be also different from the other group. You know that the whole group of new drugs now has a weak effect. We are trying to combine them with some other drugs as soon as possible from the very beginning. We are trying to make a triple therapy, just trying to increase this sort of hypoglycemic effect. But of course, all of them has pro, all of them has contra. I know that most of you definitely knows that. But somehow, our daily blood glucose self-control and our care, when we are using sulphonylurea drugs, definitely we show hypoglycemic effect, but needs more control. Maybe not as much as with insulin, but definitely more than the rest of the group which is listed at the bottom. So it doesn't matter about which drugs we are talking about. But we can see that the half-life and the duration of action is, for some of the drugs, terribly different. We have that the half-life is only a few hours, but the duration of action is 24 hours. Maybe it looks in evidence-based part, in laboratory part. But I'm definitely sure that not in all patients this effect will be achieved. And if we increase the dose too much, without distribution the dose of drug during the day, we will create that what we discussed a little bit earlier. That means hypoglycemia in some certain part of the day and hyperglycemia somewhere in the other part of the day. So, and when we are looking to the prescribing from the pharmaceutical companies, starting doses once, as some of them try to divide that into 2 doses. So it is extremely important for the companies to sell a drug which you can use only once and you have no problem and think about it during the day. So this you saw this 2-3 times a day. I think that is not a consensus. It is a consensus, but it is more the bar of whatever you try or you like to use. And I agree with that. But do we really discuss the side effects of sulphonylurea, thiazolidine, DPP-4, and so on and so on and so on with the patient when we are introducing the treatment? Saying, that is a possibility of pancreatitis. Did you have some, and so on and so on. So definitely we need much more in our daily self-control to get more information. This slide looks a little bit busy, but I will make it very simple. This part is a laboratory part. Sulphonylurea production and a lot of in vitro, in vivo different experiments brought us to the point to know the beginning, the maximum, and the end of action, creating something what is definitely evidence-based proved. But then we have the huge number of different factors which are influencing that, starting from the residual endogenous insulin, resorption of insulin, sulphonylurea, exercise, food, and so on and so on. So, and we come to the biological insulin effect as a combine of these two, and beginning becomes a real beginning, maximum, real maximum, and end, real end of action for some particular patient, moving slowly forward to individualization of treatment. So blood glucose self-control definitely has to give us the maximum benefit of that, with the self-management and the possible patient reaction a day, or with the computer analysis, actually, the adaptation and the discussing with patient about the problem. Now, coming to the problem, to the Accord study, so definitely we had a difference. Definitely we have the idea maybe secondary to hypoglycemia, but when you're reading carefully or when you're reading a comment on that, then you can see the adverse outcome was associated with high hemoglobin A1C level at baseline. It occurs especially among individuals who attempted the intensive strategy but failed to reduce hemoglobin A1C much from their baseline level and continued levels with higher than 7 while using the strategy. What actually that means? These outcomes for which the study was interrupted in part definitely show that the most of patients had not the problem of hypoglycemia. They were a part of the intensive treated group, but they had no hypoglycemia. What does that mean? That means that we gave something to our patient which we did not explain the patient appropriately, or the patient do not want to listen appropriately, calling the intensified treatment. Or the third, the patient is not able to understand what we are talking about. Making it very simple, somebody who is not driving a car, it's definitely very, very dangerous to put in Formula One car. So, for that reason, we can see that there is a lot of traps inside the regulation of our diabetes, even with such a drug like sulphonylurea for time and time. What we are usually doing with our patient? When the patient is coming, we just inform him something. He is blocked in some sort of tower. Then we call a nurse. Then we send a diabetologist. Then we have a specialist nurse. Then we have psychologists. Then we have a nutritionist. Then we have one group of drug. Then we add the other group of drug. Then we have the third group of drug. The patient is using less and less, all of that. And results disappeared. The problem is that the patient is non-motivated for such a treatment. So, and today we listen about all of that. But actually, everybody mentioned that we have the individualized, actually, our approach. But nobody say how. Nobody say how. We are just trying to add another specialist. Maybe he will achieve something. So, probably, we and all our colleagues and the specialists actually need to try to find what could be the internal locus of motivation for a patient and try to connect our idea and our wishes for treatment to that locus. So, and I think that I'm very happy to hear the psychological approach, what we should have very, very soon later on. So, that means difference in patient-centered model definitely show more autonomy, participation, planning, empowerment. Empowerment means motivation, activity, independence. So, compared with the medical center model, which we actually heard just previously. Just change the treatment. Patient anyhow do not understand what is going on. I think I judge it wrong. But anyhow, everybody has his own way of thinking. So on the other side, if we have a well-motivated patient, in that case, many times all of these people are not necessary. A patient is taken care alone. Actually needed the regular general practitioners for the prescription. And very, very rare, from time to time, the diabetologist, when something happens what we cannot understand. So looking to the blood glucose self-control, just a few small examples. So definitely that was clearly soon understandable that is the days when he has no exercise in the afternoon or when he had exercise in the afternoon. Or that actually the drug actually introduced here shows effect during the day but does not show effect during the night. So definitely we have to analyze details, but many, many data can be collected on that way. So, going to the last part, so showing potential overtreatment of diabetes in older adults with tight glycemic control. So, showing that we, between 2001 and 2010, we actually have the group of patients who were appropriately regulated. And so, most of them were treated with insulin sulphonylureas, which may lead to severe hypoglycemia. Truth. The question is how many of them are performing blood glucose self-control daily. Our findings suggest that a substantial proportion of all the others were potentially overtreated. May I ask you, is it easier these properly controlled persons proceed with a little bit more self-control or change the treatment with a lower hypoglycemic effect which are new groups, much, much more expensive group, comparing the sulphonylurea, which is old and cheap. So all of that actually shows that definitely if we are improving compensatory mechanisms, EKI actually shows that beautifully everything is regulated. So the second part is that if that is the appropriate hypoglycemic treatment, doesn't matter which age, it depends on comorbidities. And then we have the whole group of patients where we are using or low hypoglycemic effect or strong hypoglycemic effect, but without blood glucose self-control. So moving further to the two groups, insulin or sulphonylurea with strong hypoglycemic activity and possible hypoglycemia. So, or the rest of the group of drugs with lower hypoglycemia. And the question, do we have actually hypoglycemic activity? Okay, I can just conclude. So, in conclusion, sulphonylurea are the strongest hypoglycemic in non-insulin medication group. Approach to the treatment has to be more similar to the insulin treatment compared to other oral drugs. We have to respect that we have a strong drug which has hypoglycemic effect and that we have to control it. Scientific and evidence-based data about sulphonylurea are known, but individual patient reactivity is unknown. For that reason, we need self-control. Because of hypoglycemic action of sulphonylurea, blood glucose should be very similar to the self-control with insulin treatment. Better distribution of sulphonylurea during the day based on blood glucose self-monitoring definitely will reduce the hypoglycemia, will reduce the body weight, will prolong beta cell life. So maybe high price of sulphonylurea possibly could increase interest in pharmaceutical companies and also to all of us, our medical staff or us all. And at the end, just one photograph somewhere, I don't know where, in Delhi, in Mumbai, Chennai, Nagpur, Lucknow, somewhere in the 90s, with groups, with our students, hopefully seeing you again somewhere in the past. Thank you.